In the October JACC intervention, some substantial information from an NCDR analysis on the topic of DES versus BMS in elderly patients who need to be treated for chronic total occlusions. I'm with Dr. Manesh Patel from Duke University, DCRI, as we say. First, what's happening in real practice in this particular group of people?
Well, thanks for asking me to talk about it. It's important to recognize that there's an unmet need. There are patients with total occlusions of their coronaries with a varying duration from 3 days to 5 years. And in this analysis, we tried to see patients that at least were 30 days out from any event and looked at how we did with regards to total occlusions. It's important to recognize also that these are all patients that had a successful angioplasty. And in real practice, I think physicians are always wondering, first, do they need something driven by symptoms or ischemia? But then when they do, in the interventional lab, how do we get across, and when we do, which stent structure should we use? So this is sort of a real-world analysis of chronic total occlusions with long-term follow-up from Medicare.
So you've got about 30 months of follow-up. What did you find in terms of the patient population? Who did you study, and kind of give me the parameters?
Yeah, so these are Medicare patients that are undergoing chronic total occlusion opening, and so you can envision that they're older, over 65, with several comorbidities, and many of them have diabetes, hypertension, a lot of the comorbidities with heart disease.
And more than 10,000.
And more than 10,000 of these. And so the other strength with NCDR and our analysis is that we have a lot of these. And so we can analyze them. And 80% of them got a drug-eluting stent, and 20% roughly got a bare metal stent.
So when you compare outcomes across those 30 months, how did they compare for the two stent platforms?
Well, you might imagine that we tried to control for all the reasons a doctor might consider using a bare metal stent versus a drug-eluting stent, but sometimes you can't control for all those reasons. But that being said, when we controlled for it, those that got drug-eluting stents did do better long-term wise with regards to all of our outcome measures, including myocardial infarction, repeat revascularization, and long-term clinical heart endpoints.
And mortality.
And mortality.
Was an interesting one.
I think mortality was an interesting one, although I caution us to say that, you know, if you open a chronic total occlusion for symptom benefit and you don't put a patient on a drug-eluting stent, don't treat them with a drug-coated stent, it may be that you know of some other unmeasured factor on why this patient may not live as long. But that being said, those that got a drug-eluting stent for a total occlusion did live longer.
What about bleeding in terms of post-follow-up hospitalization for bleeding? What happened there?
Yeah, we notice again that it's probably because patients are getting long-term antiplatelet therapy with drug-coated stents versus bare metal stents. So there's a little bit higher rates of bleeding, but not dramatically high. I think you would anticipate in this elderly population some rate of bleeding no matter what. So there is a little bit to pay for trying to have that longer-term open vessel.
But when you compare it to the BMS, it was
very similar.
Yeah,
very similar,
it was not statistically different.
No, the rates are similar in the two groups, but the rates are a little higher than you would expect in all populations because they're older and sicker. But so, you know, don't get me wrong. I think likely what is happening is that when you get a total occlusion open, doctors do want to treat you with antiplatelet agents. These patients bleed a little bit more, but the drug-coated stent clearly had at least a benefit long-term, both for clinical outcomes, and bleeding seems similar.
So it's interesting that with 80% of the doctors who are obviously doing the bare metal stents, 20% aren't. Like you said, there may be some reason for it. Are you going to try and tease out?
I think our message is going to be that, you know, if you're going through the entire length of going through a total occlusion, which is a longer intervention and you're spending a lot more time and effort to open it up sometimes, that drug-eluting stents are clearly beneficial. And if you're not, there's probably reasons, but you have to think about those reasons when you're doing it.
Look at the specific patient in front of you.
Yeah, look at the specific patient in front of you and recognize that in these types of data sets, we don't always have these unmeasured confounders. How many of these patients have a cancer that we can't identify that they don't want to be treating with long-term antiplatelet agents or maybe reducing their mortality?
So this is JACC Interventions, and this is for October 2012. I'm Rick McGuire, Executive Editor, Cardiol Source World News.